Well, I first wanted to start by thanking the organizers. Michael and Max, thank you so much. This has been very productive, at least for me, and I've enjoyed it so far. I'm going to be focusing right now about lessons learned from technology as we've gone through, at least in Oregon, from our experience in Oregon Health and Science University in working with home monitoring for an older population, and our initial focus has been on cognitive health. And basically, this is going to be a challenging population. The chronic conditions, they typically have more than two, many medications. It's eating up a vast part of our healthcare dollars. So our approach has been to look at a scalable, remote, just-in-time continuous care, a platform that incorporates principles of health behavior change and takes advantage of low-cost people trained in health coaching as opposed to focusing on sending people or having physicians or nurse care managers be the first line of defense here. And the untapped resource of family members or informal caregivers that already exist quite often are very community-specific. It's important to have software that facilitates their meaningful participation in care, as well as the meaningful participation of care by the older adult themselves. And so we are in a research setting, but a lot of these principles apply to the commercial world as well. I just want to describe the environment where we're developing this. We have a center, the Oregon Center for Aging and Technology, that's made up by a variety of stakeholders, both the academic institutions, but also industry. Intel is a co-sponsor of this. I've worked with Spry Learning Company on developing cognitive computer games that embed algorithms for testing memory, monitoring memory, divided attention, planning abilities, verbal fluency, things that are clinically relevant. Service partners, retirement homes, people that put technology into retirement homes, as well as policymakers like the Oregon State Government, AARP, et cetera. We find it very important to incorporate the older adults in our studies as part of the design team. This is an example of a new retirement facility that went up just a few hundred feet from our new coordinated care clinic at OHSU. It's a perfectly wired, ready to go for a variety of sensors that we typically use. Not everybody has to be enrolled in order to live there, but generally we rely on what we call a living lab, a group of older adults who are pre-consented to try out new technologies for us so we can explore, find out what works, and try new interventions in a way in getting early feedback. Typically, what our approach has been to use unobtrusive monitoring, sensors in the home, such as up in the, see if I can point to it. Here is a typical, very low-cost, you can get it at Radio Shack, an X10 sensor that just does motion monitoring. We also use very simple techniques to focus the beam a bit, and so we can measure walking speeds, which is a great early indicator of cognitive decline if walking speeds change. Medication dispensers, Bluetooth enabled, knowing which medication is taken when. We have a lot of our participants have smartphones for getting intelligent medication reminders. We know what room they're in. We know when they're near the medication dispenser. We know what drugs they're on. We know the importance of those drugs. We use decision theory algorithms to determine the strength of reminding and the timing of the reminding so that we remind them when they're close to the dispenser or reminding them if we know they're going out of the home. So there's a lot of opportunity for better medication reminding and medication management. We're also involving the family members in the dispensing, appropriate remote dispensing of medications so that they can view the medication dispenser remotely through something like Skype, video conferencing. The camera from below can look at the pills, determine if it's the right number and are they being taken. let me see if I can get this advanced. Every one of our participants has a computer. A large part of our interface has to be done with a desktop computer, and part of the interventions involve interactive video exercise, our adaptive computer games, and we monitor behaviors on the computer, just motor speed from typing, repetitive words that are very common. We can monitor this. It may be noisy and context dependent, but over time, it's the kind of information that you can use to trend and fuse data, as I'll just try to point here. As you've seen these kinds of sensors, we get a variety of information where the sensors themselves are very low cost, but the really important part comes from the fusion, the intelligent algorithms that infer the context and the patient's state. So our platform, what we're really trying to promote here is that we need a system that facilitates a single health coach in managing a large number of clients. For example, similar to a nurse care manager in a disease management program, that you would anticipate they would be handling about 300 people, and depending on the complexity. The other thing is, similar to what you heard Vic Strecker talk about, we need an engine that creates tailored messaging. But in addition to the types of variables he mentioned, we're getting feedback from the monitors in the home. We know the sleep quality from the activity and sleep. We know the amount of sleep they're getting. We measure socialization, the medications, as I mentioned, the degree of physical activity. So this is done through very careful user assessment, developing a user model, and through, in addition to the monitoring information, creating tailored messaging that can be edited by the health coach, but it really helps a single individual by reminding them what needs to be talked about. How do you make the recommendations for the next week and the action plan? And the final point on this slide is multiple modules. To keep people engaged, we find that it's important to keep the information fresh, provide new goals, new opportunities for improving health behaviors. So these are the modules that we currently have. The cognitive exercise is in a computer game format. We have 9 computer games that have embedded algorithms in them for monitoring, not just the game score, but really specifically inferring working memory, inferring verbal fluency. Novelty exercise has to be self-reported. We have them select challenging, semi-challenging things, like brushing your teeth with the opposite hand for the upcoming week, something that just adds a little bit more to keep their cognitive skills fresh. We do physical exercise with an older group. We've started by being fairly conservative and just doing chair exercises in front of the computer with camera. We have a side project on interactive video exercises and games like that. But right now we are just simply monitoring whether they're watching the YouTube video and is there the appropriate level of activity from our motion sensors. We do sleep management. We have measures of sleep quality, and we have interventions that go from sleep hygiene to relaxation exercises or trying to work on their daily rhythms for sleep and wakefulness. Socialization. We've had a study here with using Skype and protocols for improving socialization originally by including family members, providing them with Skype and webcams. So it's not only the coach occasionally using the video for assessment and repeated visits, but also family members. And then I mentioned medication management. Mood management, you'll see, is a large number of these are highly intertwined, but we're adding cognitive behavioral therapy items that can be done with a lay approach and just generally using behavior activation, which most of these items here do work on. Now, this is a busy slide, not meant for you to look at it in detail, but just to say on the left-hand side, initial assessment, We measure things that others have mentioned today: health status, their goals, their motivations, barriers, readiness to change, who's home, who's their social support network, their preferred name, contact preferences, things like that. It's really important to have all of that embedded in a software platform to facilitate this coach in making a meaningful connection with each individual and yet being able to handle a large number at any one time. This informs our dynamic user model, so we know what's current, and the monitoring data that I mentioned also influences dynamic user model, and we also get the self-report data. Physical activity now is actually monitored, but novelty exercise is an example of self-report. Then we have a large message database, and for each additional module that we put in, we have to create new messages that then get selected from this model so that we come up with tailored messages. Every time the coach hits generate message, it gets something appropriate for that time based on the data that it's seeing. So this same set of data, there's one interface for a coach that I'll describe, and also for the patient. Starting with the patient, though, we try to keep the site fresh with a featured story and remind them of their weekly goals and activities. They may need to take surveys. For some people, they're able to do the surveys on their own. For others, it's helpful to have the coach fill out the survey for them via Skype, and then they have access to each one of those modules with background information as well as help in getting the activity started. This is just quickly what our games look like. There's some word games for verbal fluency. This two-dimensional blackjack, we have a measure of divided attention derived from that. Because it's not, all of this, you don't want to say, well, how good are they at playing blackjack? It's rather, can they do two things at once? Do they have the same performance in both rows and columns? We have a very simple memory game here that gets more and more complex depending on skill level, but over time we can monitor their inferred memory buffer length by understanding and have a stochastic model of how many steps they would have had to have been able to remember in order to play successfully on average. An interesting thing with our Skype or our socialization intervention, we originally, all of our protocols were based around connecting people with their grandchildren or their adult children remotely. But if any of you have used Skype, you go on and you see who else is on. What we found was that most of the conversations were actually occurring, between our participants, because they would be more likely to be online. And some fast friendships developed, and that then has modified our protocols to include this. But that, according to our participants, that's been one of the most compelling aspects of our interventions. And there's a lot of literature that shows how important socialization is to cognitive health. Can't see this in detail, but just to show that we're using cheap YouTube videos. There are a lot of very interesting chair exercises. We focus on flexibility, cardiovascular health, balance in using YouTube videos for them to view, and then looking at activity measures at the same time. We have a sleep module. We have motion sensors to look at sleep quality. One of our Ph.D. students uses load sensors under the bed and can actually measure sleep apnea simply by looking at center of mass changes. But for the vast majority of our subjects, we're simply looking at motion sensors, very cheap, and we can get an understanding of sleep quality from total amount of time in bed and number of times up to go to the bathroom, do they wander at night, and is there restlessness while in bed? And then the idea is that we can feed this back as they go through the interventions to improve sleep quality. Now the coach has their own interface. They pick the patient name, go in and look at the performance from the data monitoring coming in, and, whoops, I thought I had 2 coach interface slides. Anyway, as I was saying before, they can hit a generate message button and automatically create a message that they can tailor before sending, but if it's appropriate enough. And the other thing I need to mention that home monitoring really enables is to catch people as soon as they're off the wagon or as soon as they drop off. If they're not doing the interventions, you don't wait until the next visit, but you can intervene quickly and find out what the problem is and if you can help it. And quite often it's a technical problem. So here what I wanted to emphasize here is the new family interface that we're using to bring the family in. And I should also mention that it's important to have interfaces for clinicians, a home health nurse, a nurse care manager, somebody that specializes in physical therapy. The variety of health partners, to have a multidisciplinary care team requires software that handles project management. We're trying to give family members an active role in helping the older adult, their loved one. And it has to be meaningful, and they have to have the appropriate data. Now, some of the real issues here is what data do you share? And how do you assess from the older adult what they're willing to share and with whom? So just some studies. We've done a lot of needs assessments, and one reason for our early focus on cognitive health has been that was determined even by people who had many chronic conditions. It was their cognitive health that they felt was most important to them and that would keep them independent and aging in place. So we had a few foundational studies to give us background information on the accuracy and usability of our adaptive cognitive games and the home monitoring. And I'm just going to quick go through. We tested the automated messaging by a carefully controlled trial with coaches and being evaluated by other coaches and patients themselves. We do remote usability testing with video conferencing, talk aloud protocols while they go through sample tasks whenever we change something. And our current coaching study is comparing different aspects, different ways of intervening for cognitive health. So the lessons learned, I'm winding up here. It's so important to have your users involved in the design when you come up with technology like this, and that's something that we try to do routinely. The real challenge is not in the sensors, but in the inference algorithms for inferring patient state. It really, to do this well, to do the tailoring requires sophisticated user models. Keeping track of variables that aren't normally in technology that you see. The privacy and security of the data becomes very complicated when you have teams that involve multiple family members or multiple types of clinicians. And finally, I would just say intelligent interoperability if you plan to work with different types of sensors. So this basically, I'm trying to make a case for scalable technology that really extends the reach of lower cost professionals, that allows you to tailor, also having modules that very culturally specific coaches can use. So you can do subpopulations that's timely, continuous, and integrates this the resource of family members and informal caregivers. And I'll wind up here, and I don't know if we have time for questions.